Extended introduction script. Femur bone. The femur, or thigh bone, is the longest and strongest bone in the human skeleton. It supports the entire weight of the body during standing, walking, and running, making it essential for almost every lower limb movement. This bone stretches from the hip joint above to the knee joint below. At its proximal end, the femoral head fits into the acetabulum of the pelvis, forming the hip joint, a stable ball and socket joint that allows movement in multiple directions. At its distal end, the femur meets the tibia and patella, forming the knee joint, which is the largest and one of the most complex joints in the body. Structurally, the femur is divided into three main parts. The proximal end, which includes the head, neck, and greater and lesser trochanters. The shaft, which is slightly curved and designed to absorb stresses of locomotion. Head of the femur, detailed anatomy 1. General features. Shape, nearly spherical, forms about 2/3 of a sphere. Orientation, directed medially, slightly upward and forward. Articular surface, entirely covered with hyaline cartilage, except at a small pit, fovea. Function, articulates with the acetabulum of the hip bone to form the hip joint, a ball and socket synovial joint. 2. Fovea capitis femoris, a small, non-articular depression on the posteromedial surface of the head. Serves as the attachment site for the ligament of the head of the femur, ligamentum teres femoris. Ligament of the head of the femur. Also called ligamentum teres or ligamentum capitis femoris. Connects the fovea capitis to the acetabular notch and transverse acetabular ligament. Contains a small blood vessel, the acetabular branch of the obturator artery. In children, this artery plays a significant role in blood supply to the femoral head. In adults, its contribution is usually minor. 4. Blood supply of the femoral head. Main supply. Retinacular arteries, branches of the medial and lateral circumflex femoral arteries, from profunda femoris artery. These arteries run within the synovial folds along the femoral neck. Accessory supply. Acetabular branch of obturator artery, via ligament of the head. Artery of ligamentum teres is more important in children. Clinical note. Disruption of retinacular arteries, e.g., after neck fracture, avascular necrosis of femoral head. Ligament of the head of the femur. Also called ligamentum teres or ligamentum capitis femoris. Connects the fovea capitis to the acetabular notch and transverse acetabular ligament. Contains a small blood vessel, the acetabular branch of the obturator artery. In children, this artery plays a significant role in blood supply to the femoral head. In adults, its contribution is usually minor. 4. Blood supply of the femoral head. Main supply. Retinacular arteries, branches of the medial and lateral circumflex femoral arteries, from profunda femoris artery. These arteries run within the synovial folds along the femoral neck. Accessory supply. Acetabular branch of obturator artery, via ligament of the head. Artery of ligamentum teres is more important in children. Clinical note. Disruption of retinacular arteries, e.g., after neck fracture, avascular necrosis of femoral head. Neck of the femur, detailed anatomy 1. General features. Shape, cylindrical, flattened anteroposteriorly, narrower than the head and shaft. Location, connects the head of the femur to the shaft. Orientation, projects medially, upward, and slightly forward from the shaft. 2. Angles. Angle of inclination, between neck and shaft. Adults 125 degree. Children 150 degree. Elderly 110 degree. Abnormalities. Coxa less than 120 degrees neck shaft angle, decreased limb shortening, limping gait. Coxa valga, greater than 135 degrees neck shaft angle, increased altered biomechanics, risk of hip dysplasia. Angle of anteversion, torsion angle. Between femoral neck and femoral condyles, in horizontal plane. Adults 10-15 degree, neck projects anteriorly relative to shaft. Increased angle excessive femoral anteversion in towing gait. Decreased angle retroversion out towing gait. 3. Surfaces of the neck. Anterior surface. Broad and flattened. Bounded inferiorly by the intertrochanteric line. Posterior surface. Narrower and more convex. Bounded by the intertrochanteric crest. Superior surface. Joins head and greater trochanter. Inferior surface. Joins head and lesser trochanter. 4. Relations. Anteriorly, related to the capsule of the hip joint. Posteriorly, capsule of hip joint, with retinacular folds containing blood vessels. Medially, continuous with the head of femur. Laterally, joins the trochanteric region. 5. Blood supply. Supplied by retinacular arteries, branches of medial and lateral circumflex femoral arteries. These vessels run along the neck within synovial folds, retinacula. Clinical importance. Fractures through the neck can damage these vessels. Avascular necrosis of femoral head. 6. Capsule attachments. The capsule of the hip joint attaches along the intertrochanteric line, anteriorly, and just medial to the intertrochanteric crest, posteriorly. This means part of the neck lies intracapsular, important for fractures. 7. Types of fractures of the neck of femur. Subcapital, just below the head. Transcervical, across the midneck. Basocervical, at the base of the neck, near trochanters. Clinical notes on fractures. Very common in elderly, especially with osteoporosis. Often intracapsular risk of avascular necrosis due to interruption of retinacular arteries. Present with limb shortening and external rotation deformity. Treated often by prosthetic replacement in elderly, hemiarthroplasty. 8. Clinical importance. Coxa-vara/valga, deformities affecting gait. Stress fractures, may occur in athletes. Slipped capital femoral epiphysis, SCFE in adolescents, femoral head slips posteriorly and inferiorly relative to the neck. Surgical relevance, the neck is a key landmark in hip arthroplasty and fracture fixation. Trochanters of the femur, detailed anatomy 1. Overview. The femur has two major prominences at its proximal end. Greater trochanter, large, lateral, quadrangular. Lesser trochanter, small, conical, posteromedial. Both serve as important muscle attachment sites and levers for movements of the hip joint. They are connected by two ridges. Intertrochanteric line, anterior. Intertrochanteric crest, posterior. 2. Greater trochanter general features. Large, quadrangular projection on the lateral aspect of the femur. Easily palpable under the skin. Extends above the level of the femoral neck. Surfaces. Lateral surface, flat, attachment of gluteus medius. Anterior surface, provides insertion for gluteus minimus. Medial surface, has the trochanteric fossa insertion site for obturator externus, and sometimes part of obturator internus and gemelli. Superior border, provides insertion for piriformis. Posterior border, continuous with the intertrochanteric crest. 3. Lesser trochanter general features. Small, conical bony projection. Located on the posteromedial aspect of the femur, below the neck. Much smaller than the greater trochanter. Attachments. Provides insertion for the iliopsoas muscle, main hip flexor. Sometimes receives part of the pectineus muscle. Functions. Acts as the major lever for hip flexion. Clinically important because fractures or avulsions here severely affect walking ability. 4. Structures connecting the trochanters. Intertrochanteric line, anterior. Rough ridge running between greater and lesser trochanters. Site of attachment for the iliofemoral ligament, strongest ligament in the human body. Also attachment site for the vastus medialis muscle. Intertrochanteric crest, posterior. Bony ridge connecting the trochanters posteriorly. Contains the quadrate tubercle, which is the insertion point of quadratus femoris muscle. 5. Clinical significance. Intertrochanteric fractures. Very common in elderly, especially with osteoporosis. Usually extracapsular, so blood supply to the femoral head is preserved. Managed with surgical fixation. Trochanteric bursitis. Inflammation of the bursa over the greater trochanter causes lateral hip pain. Avulsion injuries. Lesser trochanter avulsion may occur in young athletes due to sudden, strong contraction of iliopsoas. Surgical landmark. Greater trochanter is used as a reference point in hip replacement surgeries and intramedullary nail insertions. Articulation of the proximal femur, hip joint anatomy. 1. Type of joint. The hip joint is a synovial ball and socket joint. The head of the femur, ball, articulates with the acetabulum of the hip bone, socket. This configuration allows a wide range of movements in multiple planes. 2. Articular components. Head of femur. Spherical, covered with hyaline cartilage, except at the fovea capitis. Acetabulum. Formed by the fusion of the ilium, ischium, and pubis. Deepened by the acetabular labrum, fibrocartilaginous rim. Articular cartilage. Thickest at weight-bearing areas. Ensures smooth movement and absorbs shock. 3. Joint capsule. Strong fibrous capsule enclosing the joint. Attachments. Proximally, to the rim of the acetabulum and transverse acetabular ligament. Distally, to the intertrochanteric line, anterior, and just medial to the intertrochanteric crest, posterior. This makes a large part of the femoral neck intracapsular. 4. Ligaments. Iliofemoral ligament. Strongest ligament in the human body. Y-shaped, extends from ilium to the intertrochanteric line. Prevents hyperextension of the hip. Pubofemoral ligament. Extends from pubis to the capsule near the lesser trochanter. Limits excessive abduction and extension. Ischiofemoral ligament. Spirals from ischium to the posterior aspect of the femoral neck. Provides posterior stability. Ligament of the head of femur, ligamentum teres. Extends from the acetabular notch to the fovea capitis. Contains a small artery, acetabular branch of obturator artery, especially important in children. 5. Movements of the hip joint. Flexion and extension iliopsoas, rectus femoris, gluteus maximus. Abduction and adduction gluteus medius/minimus, adductors. Internal and external rotation gluteus medius/minimus versus gluteus maximus, piriformis, obturators. Circumduction combined movements. 6. Blood supply. Primary, retinacular arteries from medial and lateral circumflex femoral arteries, branches of profunda femoris. Accessory, acetabular branch of obturator artery via ligamentum teres. In adults, retinacular arteries are dominant. In children, the ligament artery plays a greater role. 7. Clinical significance. Congenital dislocation of the hip, femoral head does not sit properly in the acetabulum. Traumatic dislocation, most commonly posterior, after road traffic accidents. Avascular necrosis, due to disruption of retinacular arteries after femoral neck fractures. Osteoarthritis, degeneration of articular cartilage, pain, stiffness, limited movement.